Hi doctors, in this video we are going to discuss the INICET November 2022 Pharmacology recall questions. And this is totally recall question. Some option may be varying, forgive me. So with this introduction, we are going to start a discussion. To start, alkalization urine is done for treating the overdosage of what type of drug poisoning? Option A, weakly acidic, weakly base, high volume of different drug, non-polar drugs. See, this type of question is a very simple question. We know the concept. For absorption of a drug, the drug needs non-ionization. For excretion, it should become ionized. Now, we know the non-ionization depends upon the pH of the environment. For example, weakly acidic drugs become non-ionized in acidic medium. Weakly basic drug non-ionized in basic medium. For absorption, it is for absorption. Whereas for treating the overdose, that is, aim is to promote excretion. For excretion, the drug should be ionized. No question. Alkalization urine done for what drug poisoning? It is for weakly acidic drug poisoning. So answer for the question option number A. Now, just I give example. The same question we discussed in our regular class, and our example also same example they ask in INICET paper. Okay, and here imagine a patient admitted with aspirin poisoning, the so-called acetyl salicylic acid drug poisoning, or barbiturate poisoning, which also acidic. We know these drugs are normally undergo renal route of excretion. So to promote excretion of acidic drug, the concept is I should make the drug into ionization. For that, the urine should be alkalized. This concept is called forced alkalization. So this question, alkalization urine done for treatment of overdose of weakly acidic drug poisoning like acetyl salicylic acid or barbituric acid. Again, another important point, the alkalization urine can be done by injecting either sodium bicarbonate, or one more important point, we can also use a diuretic called acetazolamide. The acetazolamide causing loss of bicarbonate in the urine. Thereby, this also can be useful to make urine alkalization. So question can be, which is the diuretic useful for making urine alkalization? Mean think of acetazolamide. Similar to this, I'll give one more example. Look, imagine a patient admitted with morphine poisoning. Morphine, we know a alkali substance. Actually, for treatment of morphine poisoning, we have antidote called injection naloxone. Intravenous naloxone injection. It is short acting, followed by oral naltrexone. So we have specific antidote for treatment of morphine poisoning. Of course, morphine normally undergo renal route excretion. So to promote excretion of alkali drug through urination, we do urine acidification. This is called forced acidification. And urine can be acidified by injecting either ascorbic acid or by using ammonium chloride. So the message for the first question, drugs absorption mean in non-ionized form, excretion mean in ionized form. Okay. The same type of question was asked in another session. Alkalization urine will be helping in excretion of which of the following drug? Option given are acetaminophen, salicylate, digoxin, morphine. See, that's why I discussed salicylate, called acetyl salicylic acid for excretion of acidic drugs through urination. We do urine alkalization. This is a concept. Acetaminophen, also called paracetamol. For paracetamol, we have specific antidote called N-acetylcysteine. This is also important point. What is the specific antidote for paracetamol? N-acetylcysteine can be supplemented along with one thing called methionine. Methionine. So these are important points. For digoxin poisoning, we have specific antidote called digiband. Morphine, I just not told, antidote naloxone, followed by one naltrexone. In fact, morphine is an alkali drug. For excretion of alkali drug, we do urine acidification of urination. Okay. Next question. Which of the following is true about the graph shown in this picture? They are asking about efficacy and potency based question. This type of question, very common question. We also repeated discussing in our class. Okay. Now, B is more potent than A is more efficacious than B, A and B are agonist, C is the antagonist. No, look at. Whenever they ask about potency means even on low dose, if a drug producing a max response, that's called more potent. Efficacy mean response, max response. Okay, efficacy. Efficacy mean max response. Now look at me. In this curve, look at this AD50 value. Even with the less dose, drug A producing a very good response. That is a dose at which a drug producing 50% max response. That's called ED50. And ED50 indicate potency of the drug. So A, B, C among this ED50 value very less for drug A. So drug A is more potent than all other things. So it's ruled out. And efficacy means max response. See, the drug A and B almost have the same response. So almost the same efficacy. So we can't say A is more or B is more. Okay, so A is more, wrong. Both are the same efficacy. And then A and B are against, C is the antagonist. See, all these drugs are producing action only. So increase response only. So A and B are against. That can be possible. C is antagonist, wrong. It's not possible. Okay. So answer for the question is option number C. That's why I'm telling repeatedly in log dose response curve. 3 point you should know. Shape of the curve is sigmoid in shape. 1 point. Second, in this curve, the maximum response, see 100% response, the max response is called as efficacy. So efficacy means maximum response of a drug. Okay. The dose at which a drug producing 50% max response. This dose called ED50. This ED50 indicate potency of the drug. So if a drug produces more action even on less dose mean that is more potent. Now, this is also important. Imagine it's a dose response curve. DRC. Here, this is called efficacy of the drug, and this portion, the dose at which 50% response, it's called potency. But what is most important sometimes, what happened to dose response curve in the presence of competitive antagonism? Like the question can be framed. In the presence of competitive antagonism, the dose response curve will be shifted parallelly towards the right. When shifted to right mean in this case, this efficacy is same, whereas potency decreases. So answer for the question, in the presence of competitive antagonism, DRC shifted right, where efficacy remains same, potency make it decreases. Same model question, what happened to dose response curve in the presence of non-competitive antagonism? In the presence of non-competitive antagonism, the DRC shifted down like this, coming down like this, where height alone decreases, is not moving anywhere. So the DRC shifted down, that means efficacy decreases, potency remains same. Like that question can be framed. So take a message, Efficacy mean max response. Potency mean the dose at which a drug producing 50% max response. Called AD50. This is called potency. Okay. The next question. Matching type of question. Match the following teratogenic effect of drug. The given drug name and the teratogenic adverse effects. I think straight question. Lithium, a drug useful bipolar, causes Epstein anomaly. 1 mean 2. Thalidomide. In 1960s, it was used for morning sickness. Unfortunately, it causes phocomelia. So B mean 1. Warfarin, a oral anticoagulant, may cause nasal bone deformity called Conradi syndrome. So C mean 4. And chlorphenicol in newborn baby may risk of causing gray baby syndrome. Like they can match. That means answer will be like this. So this is a very common question. We discuss in regular class some important teratogen and the important teratogenic abnormality. For example, look at lithium is absolutely unsafe in pregnancy because it causes adverse effect of Epstein anomaly, where the baby born with the tricuspid atresia. Not only this, lithium also causes muscle weakness in baby called flabby infant syndrome and also risk of fetal hypothyroidism called fit goiter. But they're asking about cardiac problem, Epstein anomaly. And then thalidomide causes phocomelia. Phocomelia means the limb buds are there, but limbs are not fully grown. It's called phocomelia. So very dangerous teratogenous. That's why when a drug absolutely unsafe in pregnancy mean they comes under category X category risk category we say X category. So dangerous, should never use in pregnancy like that. And then warfarin, a oral anticoagulant, causes Conradi syndrome, also called fetal chondrodysplasia punctata. But the main problem is nasal bone deformity. Nasal bone deformity. So warfarin causes problem of nasal bone called Conradi syndrome. Now, new drug application is done after which phase of the clinical trial? Phase 1, phase 2, phase 3, phase 4. New drug application usually we give after conducting phase 3 trial, we apply for getting approved. For approval, we write letter. So, new drug application is done after phase 3 trial. So, a small introduction to all phases of clinical trial. The main phases in clinical trial phase 1. It is about kinetic study where we are not assessing efficacy of the drug. Remember, we are not assessing efficacy. Since we are not assessing efficacy, here the participant is healthy volunteer. So in phase 1 trial, we just including volunteer to assess whether the drug acceptable by human being. That means to know the tolerability of the drug and to know the tolerable dose. Maximum tolerable dose, MDD, maximum tolerable dose. And also know efficacy. And the main aim of phase 1 is to assess the safety and tolerability of the drug. Here we don't check for efficacy. So the participant is healthy volunteer, say 20 to 100. 25 people is more than enough. And then phase 2 trial is a therapeutic exploration. Here we want to study the efficacy of the new drug. Also we want to assess safety. So this is a patient. Here the participant is patient, 120 patient. This can be single blind or it can be a double blind study, mostly in single center. Only in Chennai, only in Kolkata, only in Mumbai, like only single center study. Here the aim is to establish therapeutic efficacy of the drug. It can be we can compare efficacy of placebo or old drug. We can compare it to study, and we are also going to study the dose ranging and ceiling effect of drug. And phase 2 trial, one of the problem, since we are doing the study in one single center, it may give bias. To avoid the bias, to confirm the result of phase 2, we do confirmatory study called phase 3. So phase 3 is a confirmation of phase 2. For this, we do a large number of patients in several centers, multi-centric study, usually double-blind study. So it's to confirm the therapeutic efficacy of the drug and establish the value of drug in relation to the efficacy and safety. After doing phase 3 trial, we do analysis of all the center reports and we will write a new drug application to Drug Controller India or USFDA in America. After sending the letter, they will go through the application. If they are satisfied, they will approve the drug. Once a drug approved, we will market it. Even after marketing, we do study. That's called post-marketing study, also called phase 4 trial. Here the point is there's no need of ethical clearance because already we got clearance and no time limit. We can do any number of months or years. Here the aim is to note down any rare problem, any long-term adverse effect occur or not. So that's the aim of phase 4 study. So new drug application we apply after phase 3 trial. Based on this, one more question I also asked. In a clinical trial of 4 to 5 patients planned to be taken to find out the efficacy of new drug in multiple center. Half was given new drug and half placebo. Both patient and researchers were blinded. This indicate which phase of clinical. It's a very straight question. See, number of patients may be less, that's okay. But here they mention they want to study efficacy of new drug in multi-centric study. Okay, so when they want to efficacy of drug in multi-center, that too patient as well as researchers are blinded. Multi-centric double-blind study mostly comes under phase 3 clinical trial. Answer for question option number C, phase 3 trial. Okay, so in general pharmacology, when analyzed, they concentrated about first how the drug absorption excretion based on ionization, non-ionization they focused. Second, they focused on efficacy and safety of drug. And third, they focused on teratogenicity, that is adverse reaction. Fourth, they concentrated on clinical trial-based question, this analysis. Now, next question. Atropine cannot be used in which? Corneal ulcer, angle closure glaucoma, malignant glaucoma, acute antibiotics. Look here. Atropine, a mydriatic agent, mydriatic agent going to close the angle. So, it is definitely unsafe in angle closure glaucoma. Any anticholinergic will cause mydriasis that are going to close the angle of antechamber, thereby closing the canal of Schulman, thereby draining acoustic very difficult. So contraindicating angle closure glaucoma. This way, when talk about anticholinergic, they will cause dryness of mouth and they may cause dryness of eye, they may cause mydriasis and blurring of vision, and they causes in reducing sweating, thereby body temperature may become high, and anticholinergic causes tachycardia, in GIT causing constipation, in bladder causing urine retention. All these are important adverse effects. Based on this adverse effect, you must know the contraindicated. Remember atropine, contraindicated in glaucoma, angle closure glaucoma, and also in hyperthermia. In fact, one more important point, atropine poisoning, the treatment choice is giving physostigmine. For treatment of atropine poisoning, drug choice physostigmine. Physostigmine anticholinesterase, a lipid-soluble drug, can easily crosses the blood-brain barrier, so going to control CNS symptom as well as peripheral symptoms of atropine. That's why it is a fantastic drug for treatment of atropine poisoning. Which of following drug acts on beta receptor? The given option with the multiple options. Depipherin, phenaldopam, mirabegron, dovixamine. Look here. Depipherin is a pro-drug of adrenaline. So pro-drug of adrenaline. And we know adrenaline acting on alpha 1, alpha 2, beta 1, beta 2 receptor. So it is beta action. Phenol is a purely D1 agonist. D1 agonist. Mirabegron mainly beta 3 agonist. Beta 3 agonist. Duvixamine is actually D1 and beta 2 agonist. So this is having beta action. This is beta action. So answer can be option number C. This is very frequently we discuss in our classroom. For example, when we're discussing catecholamine, we have synthetic and endogenous. In synthetic, I discuss in classroom dobutamine, isoprene, dobutamine, phenol, same slide. Okay, so dobutamine mainly acting on beta 1, isoprene beta 1, beta 2, beta 3, dobutamine D1 and beta 2, phenol D1. And phenol D1, the D1 location mainly renal vessels, and phenol is a short-acting drug useful for hypertension emergency. But since acting D1 causing increasing renal blood flow, that's why very important. This is can be very good choice for treatment of hypertension emergency with renal impairment. Phenol used intravenous infusion for managing hypertension emergency with renal impairment. So this question mainly actions on vitamin. We can go for depipherin, mirabegron, dovixamine. Phenol mainly D1 agonist. Coming next question. A 14-year-old boy present with tachypnea and BP 160 after scorpion bites. Which are following preferred agent? Remember, scorpion bite means the best choice will be going for alpha 1 blocker like prazosin, because the prazosin not only controlling the scorpion bite mediated catecholamine induced vasoconstriction, it also going to control the biochemical and endocrine manifestation of scorpion bite. So always the best drug choice for treatment of scorpion bite mean go for alpha 1 blocker like prazosin. Straight question. Adrenaline is a drug choice for anaphylactic shock. It's a drug of anaphylactic shock. And atropine, we know anticholinergic. Ivabradine actually a funny current sodium channel blocker. This drug actually approved for treatment of angina as well as useful for congestive cardiac failure. That is ivabradine. Of course, adverse very important. It causes adverse bradycardia. One more thing, visual disturbance. Visual disturbance, sometimes causing luminous effect. Luminous effect. That means transiently there's a sudden lightness in a restricted field of vision, sudden enhanced lightness, one of the rare adverse effects of ivabradine. Next. The most effective drug for smoking cessation, the same word we're using in the classroom. Find out the most effective drug for control smoking. Options are varenicline, bupropion, nicotine patch, nicotine gum. Straight question, answer varenicline. Here, just for explanation, all these options are useful for smoking, but the most effective drug is varenicline. Look here. The first line drug useful for control of smoking are varenicline, nicotine, bupropion, cytisine. Varenicline, a partial alpha-4 beta-2 nicotinic agonist, it's the most effective drug to control smoking, but it may cause adverse effect of suicidal tendency and cardiovascular risk, but most effective drug to control smoking. Nicotine also useful to control smoking. Here the most important point, nicotine available in what formulation? It is available as a patch, inhaler, lozenge and chewing gum. Remember, there is no tablet formulation. This is important. There's no tablet formulation. It is available only patch or inhaler or lozenge or chewing gum. Bupropion, again important, one of the antidepressant comes under NDRA category. Norepinephrine dopamine reuptake blocker. This is also useful to control smoking. Cytizin, again a partial alpha 4 beta to nicotine agonist useful to control smoking. Apart from first line drug, the second line drug useful to control smoking are clonidine, a alpha 2 agonist, nortriptyline, a tricyclic antidepressant, and then we have miscellaneous rimonabant, topiramate, mecamylamine. Rimonabant actually a inverse agonist of cannabinoid 1 receptor, but it causes so many psychiatric problems. Because of these adverse effects, it was withdrawn from markets. Topiramate having actually anti-epileptic drug, also having the property of controlling smoking, but this causes adverse effect of weight loss and kidney stone. This is important point. The most common adverse effect of topiramate, weight loss and kidney stones. Mecamylamine, one of the ganglion blocker having the property of controlling smoking habit. But the most effective drug to control smoking, think of vernicillin. Next, matching type of question. Match the following regarding mechanism action of anti-arrhythmic drugs. One drug name mechanism action. I think it's a straight question. Quinidine, we know class 1. Quinidine, procainamide, disopyramide, class 1A drug. That means sodium channel blocker. Okay, that is 1. Ibutylide. Ibutylide, a class 3 drug. That means potassium channel blocker. Digoxin, a drug useful for heart failure, inhibiting sodium, potassium, it is pump, going to accumulate calcium, going to improve force of contraction, useful for low output cardiac failure. So C means D. Esmolol, very simple. Any drug name ending with suffix LYL, we know beta blocker. That esmolol, a famous ultra short-acting cardio-selective beta blocker. So the answer will be like this. Okay. Straight question. Then, in a patient with a hyperkalemia, which drug should be stopped? Easy question at patient with hyperkalemia, which drug should be stopped? That means, look at option. Furosemide. Furosemide, a loop diuretic, causes adverse effect of hypokalemia. So this cannot be, don't need to stop here. Amlodipine, nothing effect on potassium, so no effect. And losartan, very important. ARB, remember, ACE inhibitors, ARBs, and aldosterone antagonist, even beta blocker. Okay, but mostly inhibitor, ARB, and all those antagonists, they are having RAS pathway blocking property, so they themselves causes hyperkalemia. Okay, so losartan causes hyperkalemia. That's why we know ARB. This inhibitor ARB, they are contraindicated in hyperkalemia. Contraindicated in case of bilateral artery stenosis. Contraindicated in pregnancy, we discussed it as no. So losartan themselves causes hyperkalemia, so it must stop it. Metoprolol, not that much effect. It may cause minimal effect on potassium, but losartan absolutely dangerous in hyperkalemia, huge risk of hyperkalemia. So the controversy C and D mainly go for option number C, losartan. Inhibitor ARBs are absolutely unsafe in hyperkalemia, so they must be stopped. Next question. A patient who is on losartan present with HbA1c more than 8 gram. Which of the following should preferred in this patient as an alternative to losartan? Okay. Patient is having diabetes, that too uncontrolled diabetes, on having hypertension problem on losartan. Here they want to replace losartan with some other drugs. What will be the best answer? Options are telmisartan, olmesartan, propranolol, hydrochlorothiazide. So straightforward question after. Patient having hypertension, diabetes. You want replacement of losartan mean better go for telmisartan. Why? Telmisartan also the ARB. The advantage it has PPAR gamma agonistic action. That is peroxisome proliferated activated gamma agonism. The PPAR alpha agonism causes insulin sensitization. Because of this, they will promote the insulin activity, overcoming the insulin resistance. This property can be very much useful for controlling diabetes. Here, basically having uncontrolled diabetes, so better go for telmisartan, which is going to control the hypertension as well as controlling diabetes. So it's the best replacement. Actually, telmisartan simply having pioglitazone-like action. Pioglitazone, a drug useful for diabetes, having PPAR gamma agonistic property. So because of this same action, it's a wonderful choice. Okay, whereas this also ARB not favoring for this condition. Beta blocker propranolol, they are not good for hypertension with diabetes because they may cause severe hypoglycemia and also risk of masking the symptoms of hypoglycemia problem. Hydrochloride is not good because they themselves causing hyperglycemia problem, so not good. So hypertension with the diabetes mean better avoid non-selective beta blocker and thiazide diuretic. So in this question, the best answer go for telmisartan. Next, which of the following agent causes QT prolongation and used in VT? Options are quinidine, lignocaine, phenytoin, plecanate. This is what I am telling in regular class. Whenever they ask, all are the following drug causing QT prolongation except or find out which cause causing QT prolongation, mean just to watch any drug having potassium channel blocking property will cause QT prolongation. Among the anti-arrhythmic agent, class 1A drug and class 3 drug having potassium blocking property. So they are having high risk of causing QT prolongation. No good option. Quinidine, we know class 1A drug. Lignocaine class 1B drug. Phenytoin class 1B drug. Plecanate class 1C drug. So the answer is option number A, quinidine. Remember, the class 1B drug never cause no risk of QT prolongation at all. They don't cause QT prolongation. And flecainide may or may not be, but class 1A definitely having risk of causing QT prolongation. Okay, this what? Look here. Actually, when you talk about action potential of the myocardium, when you compare this with the ECG, do one thing. From here, draw one straight line. That line meeting on Q wave. And from here, draw one straight line. That line goes and meet on end of the T wave. That means they say the action potential duration corresponding to QT interval. If you know this point, look here. In phase 3, normally what happens? Efflux of potassium happening. Suppose if I give potassium blocker, if I am not allowing the efflux of potassium, this will extend and then fall like this. So this is in the presence of potassium blocker. If the potassium blocker prolonging the action potential duration, means we know action potential duration correspond to QT interval. If it is prolonging, QT going to prolong. That's why any drug having potassium blocking property causes QT prolongation. Among the anti-arrhythmic agent, class 1A drug and class 3 drug having potassium blocking property, so they definitely have a risk of causing QT prolongation. It's a concept. Okay. Next, which of the following anti-arrhythmic agent shown this effect shown in image? Say, they given easy image, this action potential duration, it's a control. What happened in the personal drug is a prolongation. So prolongation, when you say prolongation, which is going to prolong any drug having potassium blocking property will going to prolong the action potential duration. Now, flecainide class 1C drug, lignocaine class 1B drug, phenytoin 1B drug, quinidine 1A drug. See, the 1A drug having sodium blocking property plus potassium blocking property. So, definitely they have risk of causing QT prolongation. Flecainide, purely sodium blocker, it has no significant effect on potassium, no significant effect on potassium. So, they don't prolong APD. Class 1B drug, they have sodium blocking property plus potassium opening action. Thereby, they will shorten the APD. They shorten APD, whereas class 1A drug can prolong APD. So this image shows the effect of drug. The drug is class 1A drug, like quinidine or procainamide or disopyramide. Next. Match the following diuretic with the site of action. This is an infantile question, very simple state question. Torsemide, one of the loop diuretic, that means acting on loop of Henle. Acetazolamide, one of the carbonic anhydrase enzyme inhibitor. Carbonic anhydrase enzyme blockers are acting on PCT. Thiazide diuretic acting on DCT. Spironolactone, aldosterone antagonist acting on collecting duct. That's a straight question answer. Next. Based on the image, find out the antiplatelet drug acting on the site mentioned in the arrow mark. Look at the image. They mention arrow mark here. That is glycoprotein 2B3A. Look at the whole image. In this image, there is a thromboxane A2 is there, P2 Y12 is there, and then PAR, protease activated receptor is there, and GP2B3 is there. So we have targets and some antiplatelet drug acting against thromboxane A2, some may act against GP2B3A, some may acting against P2Y12, some may act against PAR, protease activated receptor. Now look here, spelling mistake, aspirin. Aspirin is a thromboxane A2 antagonist. It's a COX-1 blocker, COX-1 inhibitor, thereby inhibiting synthesis of thromboxane A2. Rule out FT5 and then abziximab, then Thiru or tirofiban. These are antiplatelet targeting against GP2B3. They ask about mention here. So answer will be option B. Prasugrel. Prasugrel. It's a P2Y12 inhibitor. Oropaxar and one more drug, new drug called etopaxar. These two are newer drug called PAR1, protease activated receptor 1 blocker. So answer is option B. Which of the following and this anti-dyslipid drug causes gallstone? PPR alpha agonist, HMG blocker, niacin bile acid custom. I think very simple question at PPR alpha agonist. The fibrates, one of the most important adversified fibrate causes gallstone formation and also risk of myopathy. myopathy, also risk of hepatotoxicity. So gallstone mean better answer PP are all for agonist. HMVs, their main problem, muscle problem, muscle problem like myopathy, sometimes myalgia, sometimes rhabdomyolysis, and then hepatotoxicity, and then teratogenicity like this. Niacin causes mainly cutaneous flushing problem, diabetes problem, hepatotoxicity problem, and then hyperuricemia problem like this they cause. Bile sequestration mainly causing adverse effect of GI toxicity like nausea, indigestion, diarrhea, and inhibiting so many drugs absorption, vitamin K absorption, warfarin absorption. Lot of drug interactions are there with bile acid sequestrants. So here the main answer option A, PPA alpha against like fibrates. Okay, we have junk fibrosol highly causing gallstone formation. Which of the following agent given prior to that surgery to decrease blood loss during surgery? Yeah, this is the drug useful for pre-operative preparation asking steroid, PTU, methanol, potassium. The state question potassium iodide. Actually, one thing called Lugol's iodine. It's a combination of 5% iodine plus 10% potassium iodide. Here the very important point, this drug useful in hyperthyroidism acting by inhibiting release of T3, T4 for follicle. Because of this action, look here, from the follicle, the T3, T4 release is blocked. So, whatever hormone, new hormone or old hormone, just stored hormone, whatever, not allowed to release. That means rapidly decreasing the plasma level of T3, T4. That means a fastest acting anti-thyroid drug is Lugol's iodine preferred in hyperthyroid crisis cases. Another greatest advantage, it is useful for pre-operative preparation where they're reducing the vascularity of the gland, so easy for surgeon to operate with the less bleeding. This is straight to the point, doctor. In fact, this time all the questions from INICET, we don't know whether taken from Dam's notes or I don't know. Okay, because each and every slide they ask question. Such a I feel happy. Okay, such a easy question. My Damsonian, I think they may be well done, very well. I think so. Okay, we'll wait and see the result. Which of the following DPP4 inhibitor is given in CKD patient without dose modification? So another straight question, doctor. All the DPP, dipeptidyl disphosphate blocker, all the DPP4 blocker undergo renal route excretion, so unsafe in key disease, which is safe. Very straight question, linaglutide. Among the gluten, the one and only gluten goes through bile is linaglutide, thus why safe in kidney failure. Whereas all other undergo renal route of excretion. All these drugs undergo renal route of excretion, so unsafe in kidney failure. That's the concept. Second section of sildenafil. This is a very straight question. We know sildenafil, a drug useful for treatment of erectile dysfunction as well as useful for treatment of pulmonary hypertension. Actually, it's a vasodilator. How it causing vasodilation? It's a selective PD5 blocker, thereby accumulating cyclic GMP that going to cause smooth muscle relaxation. It's a straight question. There's one question, somebody posted a question, but they're not given exact options. So I just mentioned the question. Finasteride inhibits which of the five enzyme? They given the question, but they only mentioned the right answer. I don't know what are other options. Anyway, it is inhibiting 5-alpha reductase enzyme. Just for points, look here. Finasteride, a 5-alpha reductase enzyme blocker. We almost dutasteride, thereby inhibiting conversion of testosterone into active form DHT, dihydrotestosterone. Remember, finasteride and dutasteride are inhibiting 5-alpha reductase enzyme. And in fact, because of anti-androgenic action, useful for one. In elderly male patient, useful to reduce the size of prostate, useful in benign prostate hypertrophy. In youngsters, in young individual, useful for prevent the male pattern baldness. In female, can be useful for managing hirsutism because of having anti-androgenic property. Now, which is which one following it is not true about memantine. We discussed in classroom, memantine is an NMDA blocker useful for moderate to severe Alzheimer. These 2 points we discussed. So this is ruled out because the true answer is an NMDA blocker useful for moderate to severe, not for mild case. The same statement we discussed in classroom. Now just to go through other option, which is not true. So answer can be either B or C. Used as a combination, yeah, can be given with the donepezil, galantamine along with the anticholinesterase. Is combination, that's ruled out. And maintained dose is 15-20. No, that's the answer. Usually the dose 5 mg, 5 mg, okay, not the 20 mg. That's the answer. Which of following is false about disulfiram? This is also common question. I think 1 year back the same question came in INICET paper. It does not reduce craving. No, it will reduce craving. It acting by inhibiting alcohol. No, 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 no. This is the wrong answer. It is acting by inhibiting aldehyde dehydrogenase. Okay. And causes accumulation of acetaldehyde leading to nausea, vomiting. Yes, right statement. Used in ethanol de-addiction. Yes, it's a drug of choice for de-addiction. Starting doses to 10 mg. I don't know whether this option given or this. Anyway, both are right only. The false statement is option B. Acting by inhibiting aldehyde is wrong statement. It is acting by inhibiting aldehyde dehydrogenase. Once again, remember, for de-addiction of ethanol, you just know the concept. Ethyl alcohol undergo metabolism by alcohol dehydrogenase and by aldehyde dehydrogenase. So in a chronic alcoholic patient for de-addiction, the drug of choice is disulfiram. Remember, it's a drug of choice for alcohol de-addiction. Alcohol de-addiction. Point 2, acting by inhibiting aldehyde dehydrogenase. Thereby, point 3, accumulate acetaldehyde. Because of accumulation of acetaldehyde, there is going to be nausea, vomiting, breathing difficulty. All this known as disulfiram reaction. Because of the reaction, patient getting aversion to take alcohol, called aversion therapy, or getting fear, apprehension to take alcohol, called apprehension therapy. And remember, disulfiram inhibit aldehyde dehydrogenase. Okay, so drug of choice for alcohol de-addiction. Next, which one of following antidepressant contraindicated in angle glaucoma? Metazapine, amitriptyline, sertraline, fluoxamine. Okay, among the four, remember amitriptyline, one of the tricyclic antidepressant. We know TCA having additionally anticholinergic action. Because of this action, they may be unsafe in angle glaucoma. I told you, atropine causes mydriasis, thereby close the angle antechamber, thereby close the canal of Schellmann, thereby problem in drainage of aqueous humor. So answer is option number B. Amitriptyline is the right answer for this question. In fact, in our regular classroom, we discussing, since TCA having anticholinergic, they must be better avoided for treating depression in elderly male with BPH because they're going to aggravate urine retention. Of course, because having anticholinergic, TCA better avoid for treating depression in Alzheimer's. Because in Alzheimer's, already there is a deficiency acetylcholine. If we give TCA, they're going to worsen Alzheimer's disease, so be careful. Which of following is a novel antidepressant? Options are vilazodone, asenapine, lurazidone, blonansarin. Look here. A straight question, I think. Okay, vilazodone is having a property of inhibiting reuptake, selective serotonin reuptake inhibitory property plus 5-HT1A antagonistic action. It is an antidepressant. It is an antidepressant. Whereas asenapine, lurazidone, blonansarin all are atypical antipsychotic. Atypical antipsychotic agent. They're asking which is antidepressant. So answer vilazodone. Next. Which of the following benzodiazepine preferred in liver failure patient having altered liver enzymes? See, most of the benzodiazepine undergo metabolism in the liver. So benzodiazepine in general unsafe in liver disease. But some exceptions are there. Based on that, they ask the question. Oxazepam, diazepam, midazolam, abrazolum. The answer is oxazepam. This also we're discussing regularly in class. Okay, look here. All the benzodiazepine undergo metabolism in liver, so unsafe in liver disease. Exceptions are we having oxazepam, temazepam, lorazepam. These three benzodiazepines are safe in liver failure. Safe in liver failure cases. So option oxazepam is suitable for here. So that's the answer. So anyway, temazepam, oxazepam, lorazepam safe in liver disease. Next. A known alcoholic patient present with a seizure and an unconscious status. Alcoholic patient, seizure with unconscious status. Which of following is an immediate management of this patient? Yeah, alcoholic patient, the seizure, unconscious, mostly a case of acute alcohol withdrawal. May go for delirium and tremor, confused status. Okay. Now, for this case, better you can go for controlling seizure, we can go for diazepam. In higher alcoholic patient poisoning, better go for thiamine B1 because they have B1 deficiency. Naltrexone useful for preventing relapse of alcoholic habits. That is not for acute episode here or immediate management. It's not. Flufenthal antipsychotic. That's also not necessary for this case. Here the best is manage the acute event by using diazepam and by thiamine. So answers 1 and 3 options are suitable. So you can go for option by D. Next. Which of the following is a safer plasma level of lithium in case of prophylaxis? Say I told in a classroom, 4 values, zero point 0.5 to 0.8, 0.8 to 1.2, more than 1.5, more than 4. This 4 value you should by heart. So now they given what is the safer level? 0.6 to 1.5, 0.6 to 3, 1.5 to 0.5, 2 to 3. Best is 0.6 to 1.5. This is what important. Lithium having narrow therapeutic index. So plasma level should be monitored frequently. As a maintenance therapy in bipolar cases, it is prophylactically. As a maintenance, keep the level lithium around 0.5 to 0.8 milliequivalent per liter. In case of acute mania, we can increase the dose, but better keep around 0.8 to 1.2, not more than this. Because when the level goes more than 1.5 milliequivalent, there's a risk of toxicity. This is also important. When will be the adverse effect of lithium going to occur? When the plasma level goes more than 1.5 milliequivalent, risk of ADR. And in lithium poisoning cases, we can do dialysis. What is the indication for doing dialysis? When lithium level goes more than 4 milligram per liter, we may go for dialysis. So here, as a maintenance in prophylactic purpose mean keep around 0.5 to 0.8 milligram per liter. Next. SSR use pregnancy mother increase the chance of which of the following in newborn. See, SSRI or teratogen, mainly peroxetine is the most teratogenic SSRI. One of the most important problem they may cause in the newborn baby, persistent pulmonary hypertension. Definitely risk is there. There's also possibility of other problem like autism spectrum disorder. Here we can say ADHD, and they may cause respiratory distress. So at the time of uh, delivery time, because of feature respiratory distress, immediately after delivery, the baby may have low Apgar score, and there is a remote possibility of cognitive and motor disturbance, sometimes delayed milestones. So definitely there's a risk of pulmonary hypertension. Others also possible adverse effect. So I think I can go for option number A. That is all possible. Okay, only one response mean go for persistent pulmonary hypertension. Multiple answer mean better go for all or possibility with this. Sorry. Next. Which of the following is more common with the oxcarbazepine as compared to carbamazepine? See, carbamazepine we know one of the standard sodium blocking anti-epileptic. It causes so many problems like rashes, hepatotoxicity, bone marrow suppression, hyponatremia, all this. But we have one thing called oxcarbazepine that is better tolerated drug having less adverse effect. But one question. Which of is more common with oxcarbazepine? Usually less ADR, but only one exception, oxcarbazepine. And comparing to carbamazepine, it causes more SAADH problem. This also cause, but SA is more with the oxcarbazepine. So high risk of causing hyponatremia. So comparing to carbamazepine, oxcarbazepine causes more of SAADH, thereby risk of dilutional hyponatremia. Now look at this. Carbamazepine. Generally, carbamazepine causes adverse effect of number one, bone marrow suppression, like causing aerocytosis, anemia, thrombocytopenia, all this thing, and severe Steven-Johnson syndrome, skin rashes, especially in patients who having HLA-B1502 gene. In this gene patient, risk of Steven-Johnson syndrome and also causing SIADH, thereby risk of dilution hyponatremia, also hepatotoxicity. But remember, comparing to carbamazepine, oxcarbazepine usually less ADR and less prone for drug interaction. That's a great advantage. But only one thing, on comparison to carbamazepine, oxcarbazepine causes more SIADH, so more risk of hyponatremia. This is one important. Which of the following is true about anti-TB drug? Isoniazid is a mycalic acid synthesis inhibitor. Yes, true statement. Isoniazid acting on cell wall of the T bacilli, inhibiting mycalic acid. Rifampicin used only in TB? No, false statement. Rifampicin useful for TB, Mycobacterium avium complex, useful for leprosy, also useful for meningitis. Like there's so many uses are there. So wrong answer. Pyrisamide induces? No. Pyrisamide neither enzyme inducer nor enzyme inhibitor, no drug interaction. Remember, Among the first line drug, rifampicin is an enzyme inducer. Enzyme inducer. Isoniazid in general microsomal enzyme inhibitor, whereas pyrazinamide and ethambutol neither enzyme inducer nor enzyme inhibitor, no drug interaction. Bedaquiline is an ATP synthase inhibitor. Yes, bedaquiline, a newer drug useful for XDR, it's acting by inhibiting microbial ATP synthase enzyme. True statement. So option A and D are true. That means option C is the right answer for this question. Next, artesunate sulfadoxine pyrimidine. It's called ACT, artesunate, artemether plus SP, sulfadoxine pyrimidine. This is called ACT, artemetherine common therapy. It is useful for treatment of state question malaria. So that's malaria. Next, a patient present with a seizure, peripheral smear shows plasma falciparum. Treatment of this condition is dash. See, malaria they given and seizure they given. That means most probably is a case of cerebral malaria. For treating this condition, currently the drug I choice will be artemisinin group of drug. So the answer will be option A, artesunate. So for treatment of cerebral malaria, currently artemisinin are the best. That to IV artemisinin is a very good choice for this case. Okay. Which are following antiretroviral drug causing palm and sole pigmentation? Options are zidovudine, emtricitabine, nevirapine, abacavir. So good question, but they ask only single response question. See, actually, zidovudine causes pigmentations of nail. Pigmentations of nail. Emtricitabine causes pigmentations of sun exposed areas like the hand and the foot here and all. Okay, so pigmentations of nail mean we can go for zidovudine. They're asking palm and sole, so better choice go for emtricitabine. Because this is typically given Goodman-Gilman, zidovudine causes nail pigmentation, emtricitabine causes pigmentations of sun-exposed areas like peripheries, face, periphery of the hands and periphery of the foot, all this. Nevirapine causes mainly skin rashes problem and also hepatotoxicity problem. Abacavir, NOTI, this drug causes mainly skin rashes problem, especially in genetically abnormal people, or may cause sudden MI also possibility. So the answer for the question option B, emtricitabine. Next, regarding mechanism action of antiretroviral drug, which of following agent acting at the site mentioned, see in this image. Look at the image. They given option A, B, C, D. So which is acting on site C? So look here, first go through. Option A. Option A, it is inhibiting the attachment of virus with the CD4 cell. That means it's a fusion inhibitor, fusion blocker. For example, enfuvaratide. And option B, inhibiting reverse transcriptase enzyme. That means we can have one thing called NRTI, one more thing NNRTI. That is nucleoside reverse transcriptase inhibitors. One more thing, non-nucleoside reverse transcriptase inhibitors. And option C, the virus joining with the host DNA by using integrase enzyme. C mean integrase inhibitors. Option D, post-translation cleavage. that is inhibiting maturation of virus. That means protease inhibitors. If you know this microbiology background, answer simple. Look here. Raltegravir, we know it's an integrase inhibitor. So the action C, mentioned C, that means here, that's answer raltegravir. Enfuvirtide is a fusion inhibitor. That means acting here. Nevirapine, one of the NNRTI. That means acting here. Indinavir, any drug name ending with the suffix navir mean they call protease inhibitor. Where saquinavir, indinavir, nelfinavir, all listed navir or protease inhibitor inhibiting viral assembly, maturation and post-translation cleavage. That is inhibiting maturation of virus. Meropenem can be used for diabetic foot, fetal neutropenia, MRSA, intra-oral infection. See, meropenem, one of the atypical beta-lactam antibody having broad spectrum activity, useful for diabetic foot, that is skin structure, skin and skin structure infection, useful for fetal neutropenia, useful for intra infection. The action of meropenem on MRSA is doubt. It is not having that much effect on MRSA. So answer can be option number A, B, D. That is option B is the right answer. Next, which of following drug causes hemolytic anemia in patient with G6P deficiency? Options are chloroquine, primaquine, penicillin, tetracycline. The single response question means straight away go for primaquine. Primaquine, a drug useful for radical cure of vivax. Radical cure for vivax. This drug, most common drug, causes hemolytic anemia in patient with GSP deficiency. So, a drug causing problem only in some genetically abnormal people, not in all people. This type of area called as idiosyncrasy. Idiosyncrasy, also called pharmacogenomics. But sometimes chloroquine also may cause this problem, but incidence are rare. The best answer for the question option B, primaquine. Penicillin, tetracycline, they don't cause this type of problem. So we can go for boldly option B. Rituximab dash. It's a very, very commonly asked question after. Rituximab, MAB, the word is a monoclonal antibody. So the polyclonals are ruled out. So either option A or B. So here that asking about target. It's acting against CD20 antigen. Very straight question. In fact, it is my very, very, very frequently asked question. Target is CD20 on B cell. We call B cell activation inhibitor. B cell activation inhibitor. The target is most important. Acting against CD20. Useful for so many things like CLL, useful for treatment of acute anemia, idiopathic thrombosis purpura, non-Hodgkin lymphoma, rheumatoid arthritis like this. And coming to ADR, it is given intravenous infusion. So most common ADR infusion reaction, but rarely one dangerous problem called PML. PML means progressive multifocal leukoencephalopathy. This is also possible ADR. So it is a very frequent question. Matching type of question. The given drug and target asking match the following drug targets. Trastuzumab. It's a monoclonal antibody useful for breast cancer, acting in HER2 positive breast cancer. So 1A mean 3. Infliximab. It's a MAB useful for rheumatoid arthritis. It's a TNF alpha blocker. That means B mean 1. Imatinib. Any drug name, any the nib mean they call tyrosine kinase enzyme blocker. In fact, imatinib is a very good drug choice for CML. In CML, there's a translocation of chromosome 9 and 22 called BCR-ABL gene. So target is option number 4. Sirolimus, immunosuppression, it's a mTOR inhibitor. So answer will be option C. So it's a very basic example day matching type of question, very simple question. And then, which of the following anti-glaucoma drug increases the trabecular outflow? Options are nitarsodil, timolol, acetazolamide, brimonidine. Look here. Brimonidine, alpha 2 agonist. Acetazolamide, carbonic anhydrase enzyme inhibitor. Timolol, a beta blocker. Remember, I just told in the classroom A, B, C mnemonic. A for alpha agonist, B for beta blocker, C for carbonic anhydrase enzyme inhibitors. These three classes of drug acting by decreasing aqueous formation protection. So these are ruled out. Nitazoxanide, a Rho kinase enzyme inhibitor. It is useful for glaucoma, promoting the drainage via trabecular route. So answer for question option number A. This is a very interesting question. Regularly we discuss in classroom. Now just look at this. For treating glaucoma, remember, just note A, B is mnemonic, alpha agonist, beta blocker, and carbonic anhydrase enzyme inhibitors. They are acting on cell body and decreases aqueous formation. Decreases aqueous formation. Mnemonic ABC. Whereas some drug going to promote the drainage aqueous. For example, myotics. We have one thing called pilocarpine, a cholinergic drug. That drug going to promote the drainage aqueous via trabecular. That is called Sherman. Pilocarpine via trabecular. And then we got something called PGF2 alpha like latanoprost or bimatoprost or something adrenaline, dipephrine. Dip is a pro-drug adrenaline. These are acting by promoting drainage aqueous via UVO-skill. So PGF2 alpha agonist, dipephrine, adrenaline promoted drainage UVO-skill. Whereas a latest point, we have something called nitarsodil and ripasodil. Both are Rho kinase enzyme blocker. They promoting drainage via calcium, that is trabecular route. So this was the question for your paper. Okay. So nitarsodil, ripasodil both are Rho kinase enzyme blocker, useful for glaucoma, acting by promoting the drainage aqueous via trabecular route. That is calcium. So I think all the questions are very simple, straight question from the classroom notes. I think you've really done a wonderful, looking forward for a good rank. May God bless you. All the best. Thank you. Thank you.